to record and perform these procedures. We also have an online website where you can find your nearest clearwax specialist if you're in the UK. So just visit our website www.clearwax.co.uk. You can either enter your postcode or your town or city and you can find your nearest earwax removal specialist. I have a very interesting case here. A client attended a few weeks ago and he mentioned on the phone that he's got an ear infection in the right ear. He's had treatment for the last couple of months, he says, with his GP, but there's no improvement. So just looking in the right ear, you can just see all this discharge, how damp and wet it is, and that's making the screen a bit blurry. So I'm just initially just trying to vacuum all this discharge, what we call otter ear, from the ear canal. And once I've removed the bulk of this otter ear that's in front of you, and it's also a lot of dead keratin, a lot of dead skin, you're able to visualize the eardrum. And this patient, as per the title of the video, requires urgent referral to ENT. In reality, this infection's been in his ear for a lot longer than 2 months, and it's caused severe erosion of his ear canal, which we'll talk about a bit later. But at this stage, I wasn't aware of the erosions. All I'm looking is straight ahead at his ear canal, towards his eardrum. So at the moment, yes, the ears doesn't look natural. It's infected, a lot of discharge, a lot of dead keratin, but I wasn't aware at all of all the other problems this patient had until I started removing layers and layers of this dead keratin from the gentleman's ear. So we're just now approaching the eardrum. Just going to be very careful. The patient was in a lot of pain prior to attending. Obviously, as I said, he's had this infection for a couple of months now. He's had it treated for a couple of months and he's known about it for a couple of months, but I'm not so sure. I think the severity of this ear infection would tend to lead me to suggest that he's probably just, after questioning him later, he kind of said, well, it could have been more than 2 months. I think this has probably been the best part of a year. That's how severe it is. In the early stages, the patient may not have been aware. Sometimes that happens. People can have ear infections and they're just blissfully unaware. They've got no earache, no active discharge coming out of the ears. So again, just trying to vacuum some of this dead keratin. There's no other instrument we can use. Forceps would not grip onto this, it's too wet. Jobson horn and ear hooks will just, you'll be grazing the ear canal. So the only means of removing this, believe you me, is suction. So again, just at this stage, all I'm trying to do is just get his eardrum visible. That's my main priority, so he can hear. And everything else afterwards, it's almost like a bonus, so we work around it afterwards. But I just want to make sure he can hear. That's the main reason why he's come today. And you can see just how wet and damp it is. Still not got a very clear view of his eardrum. I know his eardrum's just about there, but the landmarks are not clearly visible at the moment. So just treading carefully because we don't want to be touching any other structures, or that could be a swelling as far as I know at the moment. We just can't, the view's not great because of his infection, but I think that's his eardrum, just in that little tunnel at the end of the tunnel. Because it's got a lot of keratin, sometimes if you just peel it from laterally from near the entrance, you get like a whole peel all the way towards the eardrum. But this keratin is quite thick, so you're almost having to put a lot of pressure when you're lifting it off the canal wall, and then it shreds into little pieces. So it wasn't one of those skin peels where you can literally peel the whole ear canal in one go. It was just suctioning parts and bits and bobs of dead keratin a bit at a time. So this is now where it's become apparent that the patient has got a few bony erosions. So I'm right at the base of his ear canal. His eardrum is actually up and obviously in the distance, but at the angle of this endoscope is actually almost going down towards the ground, and when I'm lifting the endoscope up, so if I had to lift the endoscope horizontally to see the eardrum right in the distance, but you can see the bony erosion at the base, and the endoscope was literally tilted towards the ground, towards the floor, to get to be able to view it. So it's becoming more and more apparent now that this patient's got some underlying problems other than, well, some more serious problems, should I say, than just this infection. So I can just about see the eardrum there. His ear canal's really inflamed, really swollen. Again, just have to be very careful because he attended with earache. So I'm just using a fine end gauge, and you can just see the erosion where I am now with the suction probe. Just below that, there's a big cave there, and you'll see that during the video. But it's almost like the base of his ear canal is missing. It's a massive erosion. So he's got 3 huge erosions. He's got one at the base of the ear canal. You can just see the lining of the canal wall where the ear canal, where the bits that are missing of the ear canal, and where the ear canal almost reconnects. You can see that mark just there. And he's also got 2 very severe erosions to the back of his ear canal, posteriorly. So I've just got the fine end. I've just made a bend so I can get access in the anterior recess to get some of this discharge and dead skin off his eardrum. I managed to do that. So at this stage, the patient's symptoms were alleviated. He could hear. So I can just about see the eardrum there. Obviously, there's a lot of dead keratin. He's had this infection for a long time. That will now have to naturally shed. I can see the hammer bone, the handle of malleus. And again, just trying to mop up a bit of discharging keratin from his anterior recess, and to get access we've had to bend this fine end gauge suction probe to even get access to that part of his ear. Okay, there's the bony erosion. You can see the ear canal, just it's almost like a cliff face. It just drops. It's a huge crater there, a massive crater. I'm just going to the endoscope now. I'm tilting it down. It's not horizontal. Now it's horizontal, and now it was before it was down. So the idea now is just clean as much debris as I can. He could hear perfectly fine. I did a pressure test just to make sure there's no infection behind his eardrum. There wasn't. So as far as the patient's own symptoms, he could hear. He was very happy, but I had to explain to him that what we need to do now is get as much of this dead keratin off. So what's going on now, I hear people say, so it could be a couple of things going on here. You could actually be just suffering from keratosis obturans, which is a build-up of dead skin plugs that can't naturally migrate out of the ear. To me, it seems like he's probably got something more menacing. He potentially could have a canal cholesteatoma, which is very dangerous. And a bit later on in the procedure, you'll see the rear canal wall, the back canal wall, and where his mastoid bone is, and his mastoid bone is all but eroded. I even asked the patient during the procedure, "Are you sure you've never had a mastoidectomy, any previous ear surgery?" And he's adamant he's never had any surgery to his ear, because his ear canal, to me, especially to the rear, looked like a mastoidectomy had been performed. So you could have mastoiditis, canal cholesteatoma, and also keratosis obturans. In some ways, some of these conditions can be all interlinked. You can start off with keratosis obturans, which is a collection of dead skin. That skin just collects and collects and collects in the ear canal, and then develops into a canal cholesteatoma. So remember, cholesteatoma is essentially a buildup of dead skin in the ear canal that eventually becomes infected. Cholesteatoma typically happens on the attic of the eardrum, so the posterior superior quadrant. So when your eardrum is retracted, when you've got a retraction, it's buckled inwards, there's a little retraction pocket in the attic, in the top part. So as I mentioned, the posterior superior quadrant. And dead skin that normally sheds and migrates gets collected in that pocket on the eardrum. And eventually, if that skin doesn't migrate, it becomes infected, just like this skin here that we're removing, but on the eardrum, and then that can get very dangerous. It can develop, it can enter the middle ear, so you can start eroding the middle ear bones, start eroding the ear canal. Some people can develop meningitis because it can infect the meninges. The cholesteatoma can start infecting the skull, temporal bone, become very, very, almost life-threatening. Sometimes it's very rare, but you can also get canal cholesteatoma of the ear canal. So in this case, it could be the keratosis obturans, developed into a canal cholesteatoma, which then also developed into a mastoiditis. So the mastoid bone, the bone behind the ear itself, that got infected because of the canal cholesteatoma, and that bone starting to erode. So I've requested an urgent ENT referral via the patient's GP, but because of coronavirus and the backlog, I've urged the patient to see an ENT privately as soon as he can, because this can be, I'm just worried it's already quite dangerous, and he'll most certainly need some biopsies. He will need CT scan just to see how much erosion there is, and as an audiologist, we then have to hand over these these cases to ENT for more exploratory investigations, ordering scans and possible surgery. So that's the rim of his original ear canal where I was just before, and at the bottom you can see just a huge cave. And although symptoms were alleviated, the patient's still experiencing a lot of pain, a lot of otalgia, and this skin is such a heavy, dense layer of skin, and we really have to peel this, putting a lot of pressure. So the patient was fantastic. He realised the importance that I remove as much dead keratin as possible. So we're just on the posterior canal wall near the entrance, and we're just trying to lift this dead keratin, which has become very soggy and mushy. Hence why no other instrument would do. If you use an ear hook, you're going to be scraping into the canal wall. Jobson horn, similarly, you'll just be putting the Jobson horn against the ear canal trying to scrape this, which would be very uncomfortable. Forceps, you just wouldn't get a grip. Someone left a comment yesterday. I had a video where I was doing a skin peel. It was quite a complex skin peel. I forgot which video number it was. In fact, let me just find the video number. So some of you may be wanting to watch this yourselves. It was just a ridiculous comment. Why didn't you use a forceps to remove this very thin sheet of dead keratin off the eardrum? Just find the video number. Sorry, as I'm narrating, I'm just on my phone, on my YouTube app, just trying to look for this video. 559, most challenging eardrum skin peel. It was a 20-minute procedure. There was absolutely no way you could use a forceps to remove a thin layer of skin from the eardrum, and they've been quite insulting. I should learn to use forceps and peel it and make, I don't know what I'm doing basically. So with forceps, you need to get a grip. So you're pulling something out of the ear. At the tip of the forceps, so imagine a pair of scissors or tweezers, the tip of it is sharp. And that sharpness, the pointed bit, doesn't grip onto anything. So you have to be able to go into an object at least a few millimeters before you can close the tweezers, so with your thumb and fingers, to get a grip and then pull it out. You've got someone's eardrum, so if I'm approaching a thin layer of dead keratin on someone's ear that's stuck on the eardrum, with a pair of forceps that's pointed, I'm going to poke through the eardrum. I thought that would be kind of self-explanatory and a bit of common sense, but for some people clearly not. Anyway, so if you want to watch that video, I've left a comment there. Forgot her name, not even responded to it, but it came up on my notification this morning. So we'll just continue to work away with this dead keratin. Patience is a virtue. There's no shortcuts with some procedures. Okay, I'm just trying to remove as much dead keratin as I can, because whilst this keratin's in the ear, this keratin is infected. It's going to die, it's going to get infected, and it's going to cause more erosion. So it's just not possible we can get every single bit of keratin out today. It would be there for several hours. But just trying to remove as much as I can, and as safely as I can. So I'm just focusing on the anterior canal wall. I'm going to go back to the base of the ear canal and the posterior canal wall a bit later. And near the end of the video, you'll see the 2 additional craters, erosions that we found. We could probably almost put a golf ball in this crater. That's how deep it is. So, if you remember my videos, the deeper we go into the ear canal, the more sensitive it becomes. So there is a bit of dead keratin coating the back of his ear canal right near the eardrum. We're just going to leave that because that would be very uncomfortable for him. That's more of a fresher layer of keratin, so it's not infected per se. Here it's peeling a bit nicely on the anterior wall, so just as we're there, just get as much out as we can, just using a fine end gauge. And I didn't want to put any drops in there. I didn't want to put any sodium bicarbonate because of these erosions. I don't know what's beyond these erosions. Any drops could penetrate. I know the patient's already been using drops because that's what we've been prescribed from the GP, but I didn't want to add any more because it could have some adverse effects because of the erosions. So just near the roof of his ear canal, on the anterior canal walls at the front, just again peeling gently. So I'm having to go in and out quite a lot because we're using a fine end gauge. You can get blocked very easily with this mushy type of dead skin keratin. Just approaching the eardrum, so again we can be very careful. And we want to avoid contact with that bony part of the ear canal. You can see the ear canal there, it's very sensitive. You need a steady hand to avoid contact. Again, right near the eardrum. In fact, we're just on the eardrum there. I just want to see if I can peel this down off the eardrum. Just a bit of deco right in the anterior recess. I'm not sure if I managed to get there. I'm watching these videos. Some of these videos are a month old, so I can't remember exactly if we got over that piece. I don't think we did. Obviously, there's a big swelling and narrowing of that part of the infection. It was within the anterior recess. So just near the entrance, got this dead skin there, and you can just see this hollowing of the ear canal, the erosion. That's very, very deep into this tympanic plate, the base of the ear canal. It's probably going to require a very strong dose of antibiotics in the first instance to stem any infected bone, so you can preserve as much bone as possible. He's obviously going to need his ears clearing out regularly now, because that crater it's a perfect breeding ground for dead keratin and wax formation. The patient also had a very, very hard buildup of wax in his left ear. I think I've already uploaded that video. Let me check which video number it is if you want to watch. I think that video is number 592. So again, we're just at the entrance. You can see all that pus there, which I just vacuumed. We're on the left hand side of the ear canal now, so what we call the posterior canal. And you can see this thick layer of keratin, and there's a lot of pus there. And as I get into these layers of keratin, as I gently elevate them off the canal wall, you'll see the widening, the erosion of the ear canal. You start seeing the fleshy bits, and you'll see some of the kind of the structure of the ear canal where it has eroded. You can see just there, just on the bottom left of the screen, very big buildup of keratin, and this is why an endoscope is so amazing, because just the view, you wouldn't, if you were using an otoscope, for example, or even head loops, any other device, because you need to use a speculum. So a speculum is like a little funnel that specialists put in the ear, and this funnel is probably about 1 centimetre in depth, and it narrows. So you can quite easily miss some of the surrounding structures, and with an otoscope and microscope you just don't get the same field of view as an endoscope. And this is why an endoscope is so amazing, because you'll see parts of the ear that you wouldn't normally see with other visualization techniques. And again, so this is the second crater. It's right near the entrance, but on the left, on the back bit, and slowly but surely you'll see almost the perimeter of the original ear canal, and you can just see it there, a bit of flesh appearing just to the right of the, on the suction probe. So that there, where it's hollowed out, this hollowing there, that's an erosion. Evident to the right of that fleshy bit was his original ear canal. So this is just all additional volume of his ear canal here that we're working in. It's a bit odd, whilst I'm narrating it, I'm almost standing up trying to look over into this crater myself. I think I was actually standing up during the procedure here, so I can really angle the endoscope downwards to get the best view possible. So you can see now, you're seeing more and more flesh. So this wasn't originally, this crater, this part of the ear canal was not originally there. It's arrived and derived due to patients' infected ears. So there's dead keratin. This keratin gets infected and it starts eroding the structure, the cartilage portion and the bony part of the ear canal. And imagine going in there with an ear hook and digging it out. You don't really want to do that if you can avoid it, because you just don't know how deep this erosion is. You'll be scratching the base of the ear canal, the side of the ear canal. There we are. You can see a lovely view there of the perimeter of his original ear canal, and you can, that's the patient's eardrum, this is the back part. I'm just having a good examination now. So that's crater 1. This is right at the base of the ear canal. This is crater 2 coming in a moment. And he's also got a third one which will come in view. So the third one is there where this dampness is. So that's crater 2 to the left, crater 1 to the right. Still a bit more keratin there, and you can see where that dampness is here. There's another crater there. And this is definitely his mastoid bone. So his mastoid bone is most certainly infected with mastoiditis, and it's beginning to erode. And I suspect he's going to have surgery to remove some more of this bone, because it must be diseased. And if they don't remove it, or the infection doesn't stop, this bone will get, the infection of the bone will spread. At the moment it's on the mastoid bone. It could spread to the temporal bone, which is a bit higher up, then to the skull bone, and it can then infect the meninges, which is a liquid layer around the brain that causes meningitis. So it can eventually become very life-threatening. Oh, another thing it could be, which is, again, all these conditions kind of are similar in the sense, because they can all be a domino effect. One creates the other, but necrotizing otitis externa, or malignant otitis externa, which is, again, can be very life-threatening. It's more prevalent in the elderly and diabetic, and one of the hallmarks typically is a big swelling near the entrance now, or from the base of the ear canal. He didn't really have a swelling, it was all keratin, hence why I don't believe it's that. So just to go back quickly, as you can see, as we remove some of this dead keratin, you're getting some of this, because this is exposing the bone now. and it's almost eating into the flesh. So when you peel some of this keratin, you're going to get some oozing of blood. It's not because we've scratched anything or caused any trauma. That's what happens when you remove thick layers of dead keratin. You're going to get a bit of bleeding because you're exposing some of the structure. So this is a much better and clearer view of the second crater. So this is to the left of the major one to the right. Still got a bit of keratin. Yeah, so necrotizing otitis externa, one of the hallmarks is severe pain at night, and very prevalent with people with diabetes. But I don't think it's that. I think it's a canal cholesteatoma as a result of keratosis obturans, which is now also caused mastoiditis. So it's got three things going on: keratosis obturans, canal cholesteatoma causing all the erosion, and it's also now spread to not only the canal but the mastoid bone, which is mastoiditis. I just want to wish anyone who celebrated Diwali yesterday a very happy Diwali and a happy New Year today. So the Hindu New Year is always the day after Diwali, and our greetings is Sal Mubarak. So Sal Mubarak to anyone celebrating. Sorry, I should have said that right at the beginning. I am a Hindu myself. I wouldn't say I'm a born Hindu. I wouldn't say I'm very religious, but I'm in a sense where I think we can all learn from each other's religions, but nonetheless, I do love my culture and some of the traditions. So, just wanted to wish anyone celebrating happy Diwali and Sal Mubarak. So, again, so the eardrum is right on the right hand side upwards. It's almost north, and again, I don't know if we've got all of this out. It was a few weeks ago we took this out. I think I got as much out as I could really. Pending how much the patient could tolerate in terms of the procedure and also our time, because obviously we've got other patients who are booked in, as this is a lot more. This isn't, if I was aware the patient's got these kind of problems, obviously would have booked a lot longer, but he booked in, just said he's got a bit of discharge in the ear, he's had a treatment for an ear infection, just needed it cleared, so it seemed very straightforward. As I say, we've got an urgent ENT referral, and I've told the patient to go privately, given some details of some local, very good specialists. So that's the eardrum, that's the first crater, that's the second crater, and the third one is just beyond that bit of keratin on the left. So I hope you enjoyed that video, guys. It's a very complex one, not something that I was expecting, but it was a good one nonetheless. As I said, the patient he came back for his left ear because he didn't have any problems on the day, but I said we need to remove that. So he did come back and remove that wax, and I did look in his right ear. It was just a few days later he came back, and some of that keratin had softened because the blockage or whatever that was there was obviously no longer there, so that keratin had softened a bit and I'd removed a bit more, and he advised me that he's already booked an appointment with ENT, so no doubt I'll get a letter from ENT to update me on the patient. So I think I've been publishing a video every day for the last 7 days since last Sunday. I knew I had a bit of catching up to do. I've been very busy at the clinic with earwax. We've also potentially got some very exciting news. I don't want to say much at the moment until